It's also an opportunity, and thank you extra to cover some of the missed topics of some of the speakers of perforation and other things which are not there. I'll see how best we can go through this. This slide brings best wishes from Apollo Group of Hospitals. Then this is another great thing with a group of colleagues. We run a hub and spoke model where this case is complex. Then probably we could get it to the main place and we could do it with extra precautions and avoiding some of the complications. I should be confessing that we have learned a lot of things from master operator teacher Dr. Vijay Trehan sir here in GB Pant, and Ravinder Rao is a pioneer in Tower. We were just trying to learn and avoid complications happening in our patients. What I would like to do in coming 15 minutes or so is basically take you through some of the causes of hemodynamic collapse and give you some broad general principles for youngsters to see how best we can prevent, and if at all, if it happens, how to manage, and go into specific causes of management like perforation and then probably dissection, things like that, and show you some case example of a chip where protected PCI is what is recommended, but sake of finances, we tend to avoid it and land in trouble. And then touch upon of late, we have been having some interest in Tower too, and some of these complications of Tower, how best we can prevent, and finally conclude with an important announcement to make. As you know, cath lab, any of us would have had dissections commonly, that is vessel closures. When the vessel closes, then obviously pressures drop. Or sometimes you could develop new thrombosis, or sometimes spasm, and no reflow phenomena. All this, once the flow decreases, then the pressures drop. Heart rates go down, pressures drop. I think we need to be a little more careful and perceive the early changes, like slight bradycardia happening and patient becoming slightly restless, things like that. We'll cover it up more. And air, though it's the most lightest thing, but it can create havoc in cath lab. And all of us have experienced air embolism. And if you're fortunate enough, because nowadays we use smaller French catheters, this is not that a problem, because we don't inject too much of air even if you do it, because 5 French catheters and relatively less air goes and patient do tolerates. Perforation is again, we do see sometimes, especially when you're dealing with very complex patients, like patients who are going for earlier surgery, calcific lesions, very high pressure inflations are being done sometimes. And these unusual things like anaphylaxis, major bleeds are there even before. But before all that, what we deal is most important is the high-risk patient, the frail patient, and patients with LV dysfunction, and patients who have creatinine levels being high, recent MIs, ACS, all those are high risk. So we need to keep the patient as well as complication what has happened. Once a complication happens, it is easy to say but difficult to be. Don't panic and try to maintain. It's always good to have a critical care support or anesthesia colleague in lab, and have a good BP support and airway. Call for extra help. In our team, we always make it a point for 2 intervention cardiology colleagues to do procedure. That helps a lot. The person who is dealing with the patient directly, we are a little more stress. The other operator is also equally experienced. Probably that goes well in managing complications also. What we tend to do is quickly identify the underlying etiology. Why is it happening? Then how do you further proceed is observe what is happening clinically to patient and what are the hemodynamic changes happening to this patient. If you see hypotension is happening, patients gradually start losing consciousness once cerebral perfusion gets affected, then respiratory arrest could happen. QRS starts widening and then might go into ventricular fibrillation, and where you need to go into CPR. These are the steps clinically, all this could happen in few seconds to minute. Now, if you see the angiographic and hemodynamic disturbances, the vessels, large vessel could get occluded. Most probably sometimes the guide catheter dissections of left main, suddenly this happens. Or in dealing with a venous graft interventions or ACS type of scenarios, acute MI, no reflow, also could be equivalent to that. So sudden pressures drop and flow drops and pressures drop. And then sometimes you do poor clearance of dye because of low pressures, or sometimes aortic root injuries also. Then major perforations, thrombosis here, and the pressure start becoming narrow, and then patients worsens, and before you go into metabolic acidosis and hypotension, we should be addressing it. If you see what is the cause, again, patient has a basic intrinsic rhythm, then probably we can do IABP, which we generally done it. But generally, if patient's rhythm is also going down, we put a temporary pacemaker lead, and if facilities are available, go on to LVAD, things like that. And then inotropic support, our colleague, done by anesthesia colleagues, always helps to gain some time. As sir mentioned, intracoronary shots of adrenaline also could help. This, I'm not going to details of this, all this support, because it becomes a huge talk by itself. But whatever is available in a lab and whatever you're comfortable with, you should try to offer it to the patient. Then when it's producing further, it looks like death is imminent in this patient. Like patient should be immediately intubated and CPR started, and then fluid and inotropic support should go on. And immediately other colleague to try to gain into contralateral access so as you can address these things better. And always call or help for a surgeon. And then I always keep telling it, you can call them, give them coffee, but finally we tend to tide over the procedures most of the time in the lab by intervention methods itself. If you see that sort of ECG, something happened, Radent, QRS, ST elevations happened, most probably it could be air embolus. The pressures would go up. I thought of picking up some examples, but funnily, which commonest one I immediately couldn't pick up. But all of you must have seen how the air goes compared to that. Once you see that, most probably it happens through when you're injecting, when you're not careful. And then during other thing when it could happen is when you're injecting some sort of devices taking inside. Also, you could get in air. And of late, what we have noticed is when you're doing intracoronary imaging, if you're not careful with the flushing of the catheters, that also could take air inside. And be careful, prepare the catheters well outside, and then avoid flushing inside. Then this back bleeding method, which all of us practice before you inject, is a good method to avoid air embolism. Small amounts are generally well tolerated. I keep telling the human body is great, it tolerates a lot of nonsense, but unless you create too much, producing like something like air lock, where patient's flow gets decreased and chest pain starts happening, that's where you ask the patient to cough if he's still conscious, and then probably go into further management. So 100% oxygen, high concentration oxygen, increase the rate of heart with the atropine and probably noradrenaline, intracoronary if possible. If patient can be turned, sometimes colleagues, anesthesia people do that. And sucking of the air, whatever blood comes out, about 20, 30 ml, 50 ml, and again flushing it. And if you have a further patient is not improving, then probably take the help of assist devices. But by and large, that sort of rhythm, don't get panicked, the ST elevations happen, but immediately it tries to come back. That's about air embolism. Then I go on to coronary artery dissection, which is supposed to be covered by some other colleague. But basically, I thought briefly I would mention the type of dissections. You see it A, B, C, D, E, F. As it is going more, there is a total occlusion there after the dissection. The earlier one is just haziness, and the linear dissection and the extraluminal craters. Spiral dissection, this is what is sometimes funnily could happen with the patient by themselves in SCAD, or type E type of dissection where there is persisting filling defect with decrease of flow. Why it is important about the type is not fancy to label it, but it's also important how to manage it, because we want to manage this complications well. If generally the proximally it is happening, it is invariably because of guide catheter induced dissection. Probably we need to be careful in handling guide catheter techniques. Amplifier type of catheter, if you are using it, we need to be more careful. And the process of getting things out, also catheters tend to get sucked in and leads to proximal dissections. And mid and distal wire-induced dissections could happen, especially when you are not careful. When you are trying to push in inadvertently the looped wires, it could happen. Edge dissections, which can develop post-balloon or post-stent, we all of us know, and we try to patch up with that. And then immediately you diagnose it by angio. If you're not able to, if there is a suspicion, probably in the latest imaging modalities, like especially OCT, gives you a clear picture and also tell you what type of dissection it is, how much grading it is, whether you could leave it or tackle it. I couldn't go into details, but basically minor dissections with not flow limiting could be left. So this sort of thing, guide catheter induced dissections, don't panic. So immediately you can address some of this. I thought time is less. I took freeze pictures, but all of the loops are available with me. So immediately tackle it with the stent. Stents have revolutionized a lot of problems which were worried. We could patch it up with stents, dissections. This sort of hazy appearance, recanalized appearance especially could happen with thrombus, and sometimes spontaneous recanalization could be having associated dissection. This actually, I wish this loop could flow. Once you track the wire into the true lumen, then it goes easily. Otherwise, fiddle around too much, the entire artery could go. Then that's how you manage and treat these dissected flaps with a good result. With patient, this young fellow took them to lab, whether this is there before or this thing, they immediately called me. And once I went, then probably that could be pre-existing or iatrogenic, difficult to tell, but we re-established immediately with stenting. That's again a freeze picture for sake of time. This is aortic sinus dissections. Inadvertently, when you're handling the catheters, you could produce dissection, but don't worry too much. As long as you can patch it up with stent and then patients are stable, then tend to heal up. Unless it is too big, so as to extending further and compromising the artery. Sometimes osteal stenting there could also help to seal that. So we need to be careful in sizing of the stent in that particular conditions. That's about dissections. I'll talk briefly about perforations now. The type of perforations, basically type 1 to 5 again are labeled. Basically it is just the extravasation. This is slight more leak. This is more the staining there. This is going into the cavity, and type 5 is wire-induced perforations. These look very small, but innocuously they could produce trouble if you're not careful enough on follow. So basically some words of advice for, I request Trehan sir and others to excuse me for going through all the basics, because I thought it would be helpful to all the younger generation. When you're dealing with frail patients, females, probably you need to be a little more careful in handling. I always keep telling, though females may not like it, their arteries and they need to be treated gently. So if you apply the same higher pressure, sometimes they may not tolerate. Presentations, again, depending upon a chronic stable angina or acute MI, we need to having different plans differently. Lesion factors, calcific lesions, tortuosities, tapered vessels, bifurcation lesions, again, could have more chances of getting into perforations. Then material balloon selection. 1:1 is a basic bottom line, what we should keep it in mind, especially in the days where you use high pressure balloons, OPN balloons. You can go on high pressure, but don't go on the higher balloon size. So if you are dealing with a 2.5 vessel, on the 2.5 balloon you can go high pressure, but if you take 3 balloon and do high pressure, inadvertently you land in perforations. So never balloon a balloon out totally. Just get into the guide catheter before you remove it and take a puff and see. Sir, you said, okay, I'm just continuing. You can stop the alarm, I'll just finish in 5 minutes. So again, you can seal it off with a puff and see whether there is any leak. Then that will save some time. If you totally remove it out and you don't have time to take, sometimes for huge perforations, it could, again, patients could get into trouble. Hydrophilic wires, again, you should be careful. The wire-induced perforations could happen. Stiffer wires could lead to different type of perforation. That's about prevention. Then management algorithms, I thought I didn't have too much detailed thing because I thought somebody I have just added. But basically, immediately inflate the balloon and start infusion fluids and vasopressor supports. And as shown before, our colleague should be doing pericardiocentesis. You should be ready. Also notify surgeon, if not, give him the case directly. Then see how the patient is behaving with balloon occlusion, and monitor the patient. If patient is relatively stable, sometimes just by patching it up with high pressure inflation, or low pressure longer inflations itself could seal it. But if it's not happening, then probably if it is large vessel perforation, you might need to take a covered stent. Probably you put a second ping pong guide catheter technique. What is it? You take it and then probably do a covered stent. If it is a wire-induced perforation, distal wire, I'll show you another case examples, and mechanism of management is different. If you see this sort of pulses paradoxes, different pressures, you could see it when you're getting it. Some of this could happen. Sir already showed the rotablator getting stuck, and how patients could land in trouble. The basic principles, not to use different higher sized, and then probably keep a track on the burring speeds and many other precautions. Can't go into details of all it, but all of you should become comfortable. The latest IVL is not that technically demanding, but to modify some of these problems, the RotaPro, RotaFlex, what they call, slightly better, because the rotations at least can be prefixed, and your coordination with hand and leg can be avoided in that. I'll show you this one case of chip. We treat a 79-year-old female who came.
Srinivas, your time is over, so my co-chairs are telling that if you take another 1 or 2 minutes and finish.
Just, sir,
just okay, fine.
That's why I covered. Otherwise, I would have just rattled up everything. Okay, this I'll show, and then show. No, he told me. That's why I'm going, because to take others. Okay, this is a calcific elderly lady. 79 years, stents were done to RCA before. Then this time he started having recurrent angina. Angio was done elsewhere outside. They didn't want surgery because she also had a past history of stroke. So these are the pictures you see, very horrible looking left main. And this we didn't notice honestly because the angio was done before. This is a new lesion which is developed there. That was a thing. Then we counseled them, we told them everything. I have detailed steps also, for sake of time I have edited. But if you are working on it, initially there are a lot of procedure I have edited there. But if you are not, we planned with the protected PCI with impeller, things like that, but for sake of cost, we just put a left axis groin, kept it ready, but try to do it. In this process of itself, you see the heart is becoming slower. It will be very quick in actions. And probably, again, all the steps in the end of the full details of IVAS, other things are there. I can show it later. But for sake of it, finally, the result was okay after OP and post-dilatations. So this is the final result of the left. But what after doing that, when we notice this here, this is the post of the right. Initially, it was a tight lesion. Then again, we stented the proximal portion. The proximal also had a critical disease, and left main again critical disease, so entire flow was getting affected. That's why patient became a little unstable on table. So these to be careful. This is about a case about wire perforations, especially when you're dealing with fielder XT type of wires. Then it could be also going inadvertently. And initially we're not careful. You may miss it. Then if you see it carefully there, it starts leaking there. So result was okay. We shifted this patient, observed for some time, shifted this patient to ICU. There was no effusion initially, but patient started becoming unstable after 2-3 hours. That's why I immediately took it back and did a pericardiocentesis, and patient did well. This is another 62-year-old lady, total occlusion there. Multiple attempts of wiring were done. And then choice floppy, intermediate, cross-it, Gaia, all that is regular stuff. Then, but see what is happened. Developed a lot of staining and a type 2 perforation there, but luckily patient was maintaining the pressures. Then we took the wire in and crossed it. As the patient was stable enough to tolerate a stent, we thought we could do a stenting. The take-home message from this case is basically as long as the patient is hemodynamically stable, don't get worried with type 1 and 2 perforations. You can still finish the angioplasty and manage the patient, especially when the patient also is likely to get ischemic. The type 5 perforation, this distal wire perforation is again a difficult thing. This we sealed it with a coil. There are various other types of things which you can use it as per your convenience. Before I close, I just wanted to, we are learning TAVR techniques, about 100 plus procedures are done. Where we could avoid complications in TAVR procedure, I thought I would just briefly tell junior colleagues. Prior to the vascular access, anybody's guess that you could have allergy, other problems, but during the procedure, with vascular access getting is the most important. And then during deployment of the valves and the post-dilatation also, you could have different type of problems leading to hypotension and collapse. And the transducer errors, anesthesia, I keep joking, anesthesia colleagues keep a lot of drugs in black. Again, suddenly you don't know it because of hypotension could happen because that allergy is anybody's guess. The vascular access, basically the principle of puncturing the femoral artery in the correct site is what is important. If you do it otherwise, probably you could produce retroperitoneal hematoma that first. Crossing the wires with the stiff wire kept across the valve. Again, hypotension could happen if you're taking long time, so we need to be careful. Arrhythmias, especially in LV dysfunction patients, could produce trouble. And predilatations and annular injury, a good case managed well, was shown by Ravindra Rao. And if you don't inflate the valve too long, and that could lead to trouble. And sometimes if it is leaking aortic regurgitation post-balloon, you could have. During the deployment of the valve, if it's self-expanding valve, we have a chance to redo it, but otherwise balloon expandable valve should be as quick and as possible. Coronary occlusion, emboli, I can't go into showing each example, so mechanical complication was already shown. I think this valve, such type of valves which are underexpanded, if you properly post-dilate and good sized thing you get, then probably pressures improve. Yeah, but at the same time, you should be careful when not to do too much. If you aggressively dilate, this is one of the patients to develop a leak not into the aorta, but into the LVOT, which was again sealed by using the device. So these sort of things, I think we can go on. Some of the things are already shown. Again, I think with this I'll stop. Thank you again for your patient hearing. There are some examples of vascular access problems I had, but I think these are, all of us have experiences in preventing these vascular access problems. just for a sec. Sometimes the covered stents also are useful. If you get into trouble like this, then you can manage it. It shouldn't be, everything fails, still you could take help of surgical colleagues. After all this stress and strain, we should be happy spending our time otherwise. It's very good to have the colleagues to support during such procedures. I thank all of my colleagues, fax professional colleagues, for doing it. Thank you.